Hello, everybody, and welcome to the webinar this evening. It's called Bi-Elevate Your Scleral Lens Fitting. So we're sort of playing on the word there, elevate your scleral lens fitting, but we're saying Bi-Elevate because tonight we're talking about how the eye surface profiler works with the Bi-Elevate product from Zenlens, from Bausch& Lomb. So the Bi-Elevate lens is a terrific lens that's been getting a lot of press lately just because it solves so many problems. And we're going to spend a lot of time tonight talking about that and also talking a little bit of time talking about the eye surface profiler as we lead into that. So that's the agenda. First, a few slides on the eye surface profiler, and then I'm going to turn it over to our guests. And before I introduce our guests, I would also like to say that Carrie Rivera of Bausch & Lomb is with us tonight. So we might actually ask her to help answer a couple questions if they come up. If our guest doctors cannot answer the questions, or if they feel like Carrie would add some spice to it. And also in the background, we have Alia from Eaglet Eye. She's all the way over in Europe helping us out, and we really appreciate her being up in the wee hours of the morning in the Netherlands helping us out. So thank you for backing us up, Elena. We've got a bunch of people on board tonight as participants, as attendees, and it looks like we have people from all over the world. I'm not going to try to figure out who's the farthest away or who's the closest, but we have not only people in the United States, but we have people I can see in Latin America, the Far East, and maybe a couple Europeans. So welcome everybody to the webinar. So I'm going to go ahead and get going. But first, what I'd like to do is introduce our two guests that are going to help us tonight. And that's Dr. Sheila Morrison and Dr. Alia Cappellani. And Dr. Morrison earned her Doctor of Optometry and completed a master's degree in vision science with a focus on scleral lenses, along with a residency in cornea and contact lenses from Pacific University College of Optometry. She served on the faculty at the University of Houston College of Optometry, facilitating education and research in contact lens and cornea service. She is a fellow of the Scleral Lens Education Society, and currently Dr. Morrison practices at Mission Eye Care Center in Calgary, where she is the co-residency supervisor of the Mission Eye Care Residency in Cornea and Contact Lens. And she's also an adjunct faculty on the adjunct faculty at the NSU Oklahoma College of Optometry. I've been there. That's an interesting small little town. And it looks like Dr. Cappellini might have a relationship with them as well. But Dr. Cappellani received her Doctor of Optometry from the University of Waterloo and completed her cornea and contact lens residency at NSU Oklahoma College of Optometry. She is a fellow of the American Academy of Optometry and a fellow of the Scleral Lens Education Society, as well as a diplomate of the American Board of Optometry. She also works and practices and assists at the Mission Eye Center in Calgary. So welcome, ladies, to the program. We really look forward to hearing what you have to share with all of us. So first, let's talk about the eye surface profiler and elevating your scleral lens fitting with data, with scientific information. Now, I'm only going to share, I don't know, 7 or 8 slides. For those of you that are on listening tonight as attendees that have an ESP, you know that we typically do a virtual demonstration, which lasts 45 minutes. So for us to really give somebody a thorough introduction into all the software, all the maps, all the different screens, all the data that we collect, it takes about 45 minutes. And we are not going to do that tonight because we really want to get to what Dr. Morrison and Dr. Cappellani have to share. But I will do a brief introduction of the eye surface profiler to give you a general idea of what we're doing. And if you are interested in more thorough demonstration of the product, a virtual demonstration, just contact us, and we do it all the time. We'll be glad to set something up for you. Also, in the chat is where you're going to leave questions. So feel free to leave questions in the chat. If it's something general about the eye surface profiler, Elena might answer it while the chat's going on. Otherwise, we'll probably hold the questions until the end. And there will be a poll that we will run after the doctors start their presentation. So be ready for the poll and be ready to answer the questions. So back to elevating your scleral lens fitting with data. And we all often say that there's a transformation in scleral lens fitting, and that's due to several different factors. One is there's just a lot more research around the ocular surface and a lot of publications that bring light to the scleral shape and just all this extra understanding of the sclera. And one of the things we've learned with all this research and with all these publications and presentations is that the scleral shape is most likely asymmetric. And you cannot really predict the shape of the sclera from the cornea. And if you look at the numbers down here in the lower right-hand side, you'll see that only about 6% of scleras in this one study were spherical. The rest of them were not. So we need more accurate sclera data to help improve the fitting process and reduce that learning curve that everybody goes through. We frequently say that somebody might have to fit something like 60 lenses before they're ready to really get good results without data. In other words, it's a little bit more of an art than a science. So the eye surface profiler helps address this. We provide more information, cornea, limbus, and the sclera, and there's no more guesswork. It's objective analysis of the entire cornea, limbus, and sclera. We can pick up things like pinguicula and other scleral abnormalities. And so it is a technology that was built to help fit lenses, not only scleral lenses, but also ortho-K lenses, RGPs, and so on and so forth. And this is a kind of map. This is a 3D rendition that you would see. And I'm going to see if we might have a map later on. So I'm going to make another comment on that later. But the characteristics of the eye surface profiler, it's a corneal sclera topographer. So we're getting the cornea and the sclera as well together. We can get out to 20 millimeter diameter image. Some people get more. No extrapolation or stitching. We're collecting 500,000 data points. And at the cornea, we have 2 microns of accuracy, and at the sclera, 10 microns. It's a very comprehensive software package, 14 maps, 2 calculators, over 18 ocular parameters. And what we do to essentially collect the data is we're using a camera head that has 2 cobalt blue lights in it and 1 camera. And so we instill fluorescein in the eye, and as part of the workflow, we take an image with the camera, and the fluorescein is necessary for us to collect the data that's reflected back by those 2 lights in a Fourier transformation, which then ends up giving us a height profile. We are measuring height. We're not measuring curvature, even though we do have a couple maps that are curvature maps. What we're primarily doing here is measuring height. And this is where I'd like to, say that there's a couple elements to the so-called science and magic of the eye surface profiler. One of them is what you see here. The dark colors are deep below the reference plane. Lighter colors like greens are about level, yellows, and then reds are high. And so here you've got the cornea in the center. This is in a 3D plane. And then you've got part of the sclera down here, and you can see how deep it is. You can actually see what you're dealing with the entire eye, the surface of the eye. This is something that some of you that are watching tonight may not really have seen that clearly before. With the eye surface profiler, we collect the data, and you'll see a lot of these images later in the presentations by Dr. Morrison and Dr. Cappellani. You'll see many more of these maps, and that is part of the magic. The other part of the magic is what we call a first lens algorithm. So what I just showed you, and here's a Bi-Elevation map right here, and you can see the cornea and you can see the sclera. a lot of data and that you may not have seen before or may not have clearly understood what a sclera looks like and how strange it can be sometimes. But that's part of the magic. The other part is what we call the first lens fit algorithms, where we take this data and working with Bausch and Lomb, we can send this data to them and they have our software. Carrie's staff is well trained on our software and they receive your software package. They pull it up on their software and they are looking at exactly what you're looking at. So no more calling up a consultant and trying to have them imagine what your problem is or what your challenge is when you say that at 130 degrees at about 7 millimeters in radius, there's an irritation on the sclera. What should we do about it? Or try to send them images, download stuff from the slit lamp or from an OCT, whatever it might be. We don't need to do that. Instead, pull down menu, you select Bausch and Lomb, the Zen Bi-Elevation lens. In this case tonight, we also have the other Zen products from Bausch and Lomb are also in this pull down menu. And you click a button and up come the parameters that typically Bausch and Lomb would prescribe for this particular lens. And then when you click a submit button or a direct connect button, all this information is sent to Bausch and Lomb on an order form that pops up on your browser that's pre-filled. And you can also pre-fill the over refraction data. And Bausch and Lomb gets all that. And now they can work with you to make a great lens. And Carrie, I'm not to put you on the spot, but I was at a trade show once where Carrie came over to our booth with the doctor. And after she explained to him very clearly how Bausch and Lomb goes through the process of evaluating the images and the data that has been sent to them, she looked at him and she said, just send us the image, doctor. We'll make you a lens. And that's what Bausch and Lomb does. So now I'm going to stop sharing my screen and I'm going to hand it over to the, Dr. Morrison and Dr. Cappellani.
Well, thanks, Ted, so much. We really appreciate the introduction. One of the things that I'm thrilled to do today is end a long day in the clinic where we've both been super busy and kind of debut with Alia, because we spend a lot of time working in the same clinic. But as you know, sometimes coworkers actually spend very little time together when the practice is very busy. So cheers to a good full day. And we're really happy to have you here tonight. Thanks so much for tuning in. We've been really excited to prepare for this presentation. And in particular, this last couple of weeks, we've really made a special effort to pull some cool cases so we'd kind of have some neat things to share with everybody. As far as our outline, we've got a little bit of a direction of where we're going with this presentation for you. So you can just read this over to yourself. But basically, our goal is to take you from maybe, in the last decade where we've kind of gone with traditional style scleral lens fitting, go through some challenges that we see in the clinic that come up with ocular shape misalignment, and then elevate. So we want to utilize some of the lessons we've learned when it comes to ocular surface mapping, how that translates into lens designs that are more optimal and with a little bit better outcome for some of our patients that have struggled with misalignment. And then we'll go through the Bi-Elevation 360 really by highlighting a few kind of fun cases. Now, traditionally, scleral lens fitting, always I like to start off with a little bit of a kind of an anatomy lecture, because it's very important as we design lenses, speak to our peers, look at communication with manufacturers, that we're all kind of speaking the same language.
Yeah, so before we get into the Bi-Elevation design, let's establish some basics of designing a scleral lens. And so when we have are fitting a scleral lens, we have to bolt over the cornea, and this contains the bolting chamber that negates the corneal astigmatism. Then we have to clear the limbus fully and then land on the sclera. And so the anatomy of the scleral lens, there is the optic zone, that's the bolting chamber, the transition zone, and then the edge clearance there. And so the transition zone is highlighted here in the slide in orange, and it's kind of in the middle of the lens, maybe the forgotten part, because we're like, are we clearing the cornea? Yes, check. Are we aligned to the sclera? Yes, check. And maybe the transition zone has been forgotten about, just like kind of a middle child is forgotten about.
And tell my sister that.
And so that's what we're gonna chat about here today. But before we give away any spoiler alerts or anything like that. Maybe we'll talk about how technology can help us establish the design of the sclera and how these lenses can be designed to maybe more contour the cornea and the sclera. So we have the Eaglet over there that Ted had just mentioned. You know, it's 2023, 2024 almost. But Sheila, I know you like vintage things. So how about you chat about this vintage look
I
at
think
things?
it's, I really think it's an influence of my residency director, honestly, Pat Caroline and our team out of Pacific. I don't know anyone that's out there that's visited. We have the museum, and I always love to look at the history of how we build things. And, you know, going from the past, I mean, the instruments that we've had, things have changed dramatically, but the one thing that has not changed is the kind of desire to collect data. And as Ted mentioned, you know, there is an art to fitting contact lenses, and that is certainly something that, you know, even within all of the technology that we have today, the art is just, that cannot be lost. So that is a part of fitting. The science though, so how do we collect data? How do we translate imaging that we can generate? So today we have the ability to utilize tech to generate digital images. Ted already did a wonderful job going through some of the capabilities, but really we've come a very, very long way in terms of what we can do to collect data. And really the basis of what we do in our clinic on every single patient that comes in for a contact lens refit, specialty fit, new patients, old patients, is we start off by evaluating physical structure, because that gives us a clue as to what they could be a physical candidate for. And then we start to explore, who is this person? And so data collection starts with measuring ocular shape. Now, where we've gone over the last couple of decades has also, technology has changed, so have our fitting philosophies. You know, our manufacturers initially in fitting sets, you know, as recently as maybe a decade ago, fitting sets were all typically with, you know, a standard spherical haptic for majority of the lenses. And as we started to explore data generated by ocular surface mapping tools, corneoscleral topographers, we have been generating information and databases about what is the true ocular shape. And in many cases, it's, you know, it comes as a surprise when we actually look at data, but in other ways not, because the reality is that no two humans are alike. You know, the eyes have their own unique fingerprint, and that is the case when it comes to looking at ocular shape. So where in the past, we traditionally, where we're talking traditional scleral lens fitting in this section, I would routinely take a look at ocular surface maps and understanding that the scleral lens just essentially, when I'm telling a patient or teaching a student, jumps right over the irregularity. We ignore the cornea, look at that ocular shape. So here are a variety of different scleral shape patterns that historically and not so historically, recently and currently, we look to this data to design a haptic of a lens that's most likely going to align with the ocular surface that we're putting the lens on. So we have with the rule toricity, against the rule, oblique toricity. And in fact, most patients today are actually more irregular than anything. Now, kind of the cool thing about where we are today is, you know, it's not necessarily a new concept looking inside of the sclera for optimal fits with our scleral lenses, but the Bi-Elevation design and the kind of recent sort of surge in popularity of this design has really provided us an education tool. It's really helped us actually in, you know, having communications with the lab and specifically modifying this lens design to help to understand, you know, why has it been in the past that some patients that we've had failures with traditional or you know, conventional scleral lens fitting who fail, maybe we have to, for some reason, can't get the comfort, can't get the lens to center, we'll move them into impression driven or more of a freeform style. You know, why is that? Well, Bi-Elevation has been really cool to mitigate some of these challenges. So, you know, what are the challenges when it comes to ocular shape misalignment? So why do we even care? That's what our next section is all about. And so we have a question for you. And it's a poll that we're going to run that we'd like you to just participate. If, you know, if you were in person, everybody, you know, loud and proud, pop your answers in. So which of these frustrating things have you encountered whenever fitting your patient? So is it decentration, conj prolapse, you know, midday fogging, or all of the above? So, you know, when it comes to consequences of scleral misalignment, I mean, you know, we know that the fitting success when it comes to scleral lenses is not just reliant on the optic, really. It is heavily reliant on that fitting relationship between the cornea and the sclera and that piece of plastic. And if that shape is a mismatch, we're really getting nowhere with the success of our outcomes. So we'll give it just a few more seconds here, just to finish off this poll. And maybe, Elena, you could nod if you think that we've had any participants, if you want to share the answer, and we'll move forward with the next section, which is going to go through some of these complications. All of the above. I love it. You guys we're all practicing in the same era, the same everything. This is absolutely, it's not surprising, but let's go into the three. So midday fog, that's okay. Midday fogging was bigger. Decentration was second. And then what was the second? Anyways, we'll go through these right away here. So when it comes to lens alignment, if we only look at that alignment out on the sclera, sometimes it can be very misleading. And this is something that is overlooked unless you're really taking time. You take a look at the front of an eye with a scleral lens on it, and the haptic could be just perfect. But when we take a closer look, like in this optic section, sometimes that fitting relationship can be a little bit misleading for the cornea, where a patient could kind of look good at the limbit or at the landing, but in reality, there's a mismatch between that corneal shape that can lead to really serious complications. Now, some of these consequences can be, a pretty big deal. Now, I know Dr. Cappellani and I, or Alia and I, we casual Wednesdays, have spent some time discussing these things before this. And I want you to maybe just go through these slides next so that we can kind of teach everybody out there what exactly we're talking about.
Yeah, so the amount of times I've been personally victimized by inferior temporal decentration is countless. Oh my goodness.
I love that, victimized. I like that. It's not me, it's not you, it's the lens.
Yeah. So if we think about why this is happening, the scleral lens is not aligned to the sclera. And so if we think about the ocular anatomy, the nasal edge is a little bit flatter versus the temporal edge is a little bit steeper, and the lens wants to fall along that steeper edge, fall down it. And so it moves off to the temporal side, and then with gravity, of course, it pulls it down as well. And so when you think about the lens optic, it's not centered anymore. The patient's not getting that clear, crisp central vision. And as well, up in the superior nasal edge, we're getting touch or close to touch, versus at the bottom, we're getting this huge gaping space. If you picture like big belly hangs low, large excessive amount of vaulting at the bottom and excessive clearance. And so you can see the picture of our patient here down in the corner. You can see that uneven scleral lens there. And then as well on the OCT cross-section map, we have way more at the bottom than at the top. And so a result of this excessive clearance at that bottom there is there's a fluid force, and this fluid force can kind of suck up some of the loose conjunctiva at the bottom. And that referred to, of course, as conjunctival prolapse. And so that can kind of fold over the cornea, cause inflammation, lack of oxygen to the eye, and this lack of oxygen can eventually lead to these little blood vessels that are growing that we don't want, in addition to ultimately patient not being comfortable there. So one of the biggest common complications that we have, that we're always battling gravity.
Yeah, no, I love the analogy of the big belly hangs low, and it's those ocular shape kind of studies, being with that kind of steeper temporal side, nasals flat, lens always wants to go to the path of least resistance. And that's, again, really just what we're dealing with is that mismatch. So if we have not an appropriate match with the shape versus plastic, and, big gaping belly, sometimes those lenses will decenter, causing things like prolapse and other kind of complications. Now, fogging was a big one. So everybody out there kind of seemed to like fogging, and I would agree. Midday fogging is a huge issue for probably at least a third of our patients.
Yeah, we always have those patients, we have the nice delivery of the lens first thing in the morning, they're seeing great, magical moment. And then, they come back 4 hours later and our patients are like, oh, it's all hazy now. And you're like, oh man, what? And so then we look into the lens and there's all this fog in this post-lens tear film. And then so that's from the lens not being aligned to the eye, movement on blink, the fluid is kind of rushing in under the lens sometimes. And so we have to try and find some ways to realign the lens to the eye, and so that we can kind of stop this fogging from happening.
Yeah, fogging is such an interesting thing, and there's multiple different etiologies of fogging. Researchers, there's several, Maria Walker at the University of Houston, for example, looking into different types of fog. Sometimes it's a product of the eye itself, an inflammatory response. Sometimes, like you said, it's that accumulation of debris that's getting under the lens. And a really important thing to know it's not a new piece of information that alignment of the lens affects midday fog. In fact, Visser back in the, back in maybe I can't remember, 15 years ago, maybe a little bit more, published one of the first papers that was looking at what kind of things can we do to, improve fogging. And one of those things was changing from a spherical to a toric or more aligned haptic. Now, okay, we're going to get into the alignment piece to mediate fog. But just as a clinical pro, what are your top couple tips on outside of alignment for clinicians? How do you handle fogging?
Yeah, quick tips here. Maybe fill the bowl of the lens with something maybe more gel or
More
thicker
viscous,
fluid,
okay, check.
some more viscous. Or additionally, we can kind of maybe treat the ocular surface disease, some sort of
Love that
allergic
one.
condition, putting in an antihistamine drop-in before a lens insertion or something like that.
Awesome. And then the final thing, just another clinical pearl, not related to Bi-Elevation, not related to ESP. We want to put in little pearls as we go because that's way more fun for us. We make sure you're understanding what the fog is. Is the fog posterior reservoir fog or is it anterior surface fogging? Because those are two very different beasts. And so that, typical, the front kind of non-wetting fog happens when a patient will put a lens on. It's like a dirty windshield initially. Midday post-reservoir fog typically happens after some amount of wear, and it can worsen throughout the day.
Okay, so now we have some problems that we have, and we have maybe some ways to kind of fix it, but we're still not perfect. And like me being a perfectionist, we need to find some ways to maybe more align the lens to the eye. So let's move on to maybe ways that we know in regards to lens alignment to mitigate some of these issues of the consequences of the scleral lens.
Love it. Time to elevate our practice.
Exactly.
So we're going to move into the next level. So, the way of thinking has changed. And I know for me, it's been, again, like a steep learning curve when I started playing around with this design, and also having the opportunity to work with some of the companies, for example, ESP or Bausch & Lomb, to kind of help to present some of this data and share our cases. It's actually a really cool concept that has created a new way of thinking when we consider our old former selves, looking at strictly just cancel the cornea, just what does the scleral shape tell us to do with the haptic, jump over the garbage and just figure that haptic out. Well, the new idea that we have gotten, it's not really new when you look at success with freeform and impression-driven designs. But again, this is a really wonderful opportunity to focus on why some of those designs could be an improvement over, a failed decentered lens. While we have learned that toricity can be found at the sclera, we know from our traditional style, but also largely within the scleral vaulting chamber. It's intuitive. It's not a surprise, but it's something that I personally have not really paid direct attention to until, again, recently. Now, some of the things that must be considered when elevating your scleral lens fitting, and especially with a Bi-Elevation design or any other type of design that follows a similar sort of change in that transition zone, is we're not only looking at the sclera, but also mid-peripheral cornea, limbus, including maybe even the differences between the width of the iris and the height of the iris. And most commonly, those values are different. So vertical versus horizontal have different needs. Again, we know this about anatomy, but this is a cool way to build it into our lens designs. Now, moving forward into this way of thinking, as opposed to out to in to out, is what we're kind of starting to explore. So kind of creatively designing a lens, what does it start with? So corneal alignment. So we're looking from the center out. We can predict the diameter of a lens looking at HVID. That's HVID driven. And our landing then is on the outermost edge extending from that corneal alignment. And those zones are connected. And what we really want is harmony. We want everything to be in harmony from all of those zones. And that's where the Bi-Elevation sort of style of lens really focuses on the transition, which is just kind of a really cool concept. Profilometry data has allowed us to not only learn about the eye, so our knowledge of ocular shape has really grown dramatically and just leaps and bounds. So many of our colleagues out there have had, incredible, publications and reports and all these kind of reports driven from profilometry data or driven from oculoscleral topographer data. And what we do in our practice is we use it really heavily to help to make decisions in the clinic that are most effective for patients. So how do we do that? So designing scleral lenses with our profilometry data is actually really quite simple. This is an example of, Ted mentioned the bi-sphere elevation map, and kind of the cool key thing about profilometry is that it not only, it looks at both the sclera and the corneal shape, and utilizing two best fit spheres for which the elevation data is compared to, the unit can take any given cord. So if we're fitting a lens at 17 millimeters, smaller at, 15, whatever it is, the instrument is capable of collecting height data and turning that into the sagittal height of the eye at any given cord. Now, our first lens fit algorithms, you'll see on the bottom right-hand corner, Ted had one up earlier, and it's just a wonderful way in the clinic to just very quickly use the data, add your apical clearance, typically about, 200, 250 microns, and click, and it gives you the recommended sagittal height of a lens that would best match that eye shape. Now, when we look at lens diameter, again, largely in our clinic driven by the iris diameter, we do see this patient didn't have a huge difference between vertical and horizontal, but I see more times than not, vertical being, smaller, horizontal wider, but again, every patient's different. So that's why collecting data is so important. Now, manufacturers are all going to have recommendations for what does it mean or what lens diameter is appropriate for a given iris diameter. So I'd encourage you to just take a look at the fitting guide for whatever lens you're using. So, Zenlens has a guide that sort of outlines exactly sort of what diameter you may choose for what given iris diameter. What would you choose, just to kind of give, again, clinical pearls, and this is just what we do. Doesn't mean it's perfect every single time, but what would you choose? What diameter is your cutoff? Would you say for a 17 millimeter or a 16 to go to a 17, for example?
I think it's 11.8 as per the fitting guide.
Perfect. So yeah, follow the fitting guide. It's great. And finally, landing alignment. So this brings us into kind of that concept in the story. So I love stories. It makes it a lot more fun to tell and to listen to. And so bringing us back home to the story of where we came from, we have the spherical sclera. But then we realized, no, we can't just fit scleral lenses, with a spherical haptic. It doesn't really align. Now, okay, scleral lenses with toricity, but only further in the periphery. So that's been great. I mean, quite honestly, that's given us huge improvements in our ability to, fit more complicated eyes with more success. But now we have this kind of like next level thinking of scleral lenses with toricity built into the lens design at the limbus, which is really, really incredible. Now, I had a call a friend day today because we were looking for this paper or kind of a poster that was presented at the GSLS, I think last year, the year before, that helps us to kind of like guide some of these clinical decisions and highlights and introduces the next section, which is how exactly specifically are we using the data to generate ideas of what curves we want in our scleral lenses. So this is a poster, Jason Jedlicka, again, call a friend. Thank you, Jason, if you're out there somewhere. That was a good SOS. He sent this over about an hour ago so we could pop it in. And I think, Alia, if you don't mind, just kind of explaining the highlights of this one.
Yeah, so what Dr. Jedlicka found at the Indiana University study here is that at the 16 millimeter cord, so kind of where a scleral lens is landing, there's about 180 microns of toricity. But interestingly enough, it's at about a 12 millimeter cord, so kind of at the limbus, there's actually about 2/3 of that, so about 120 microns of toricity right at that limbus there. And so kind of the take home there is that the toricity is not all at the sclera. There's actually, 2/3, the majority of it is actually at the limbus. And so our old self, our past self is maybe putting that toricity all in that haptic zone, the compensating for the 180 of toricity in that haptic zone. And maybe that's not actually how we should be fitting. Maybe we should be actually putting it within the internal aspect of the landing zone, or kind of within the vaulting chamber a little bit, to better align the lens to the eye.
Now, I'm going to make a point as well that it comes up is there's no cookie cutter. So this is a study that shows 2/3 of the toricity of that overall eye shape starts more inside than we thought. We do have patients in the clinic, including one fun case today I'm excited to share that does highlight just, this patient didn't follow that rule. Is more of a 1/3 on the inside, and the haptic took the, or the sclera had more toricity. So that is where data, we have averages, we have studies, we have what we can expect, but it is always so valuable to measure every single eye as its own unique beast and creature, because I find all the time things that fall out of normative data, and that's where we can really kind of cut the line and make decisions just a little quicker for those patients.
Yeah, and so here's a cross section here. For a landing zone, the ideal fit of a landing zone is actually kind of the full haptic there landing along the eye, kind of nice, kind of sticking the landing nicely. But there are times where maybe we just have that little edge digging into the sclera, and so we get that toe blanching. Or maybe there's times where that heel is digging into the conjunctiva there, and so we're getting that heel blanching there. And so what we really want is more of that kind of full foot landing onto the sclera there. And this can be seen here in this next slide, where the eaglet does do a sagittal height calculation. We have the shorter cord length, so at about the 13 millimeters, we see that 300 micron difference of toricity there between the two major meridians. So for example, like up and down or and side to side, the difference there is 300 microns versus out in the periphery at around 16, 17 millimeters out, where the very edge of the lens is landing is about 550 there.
I love this patient example case because it took a minute for me to kind of figure out and navigate exactly how to read the data. And so just in another way of in summarizing, basically the overall toricity of that eye is about 550 microns between kind of the highest and lowest points. The majority actually, well, about around half, but 300 of that 550 happens at that 13 millimeter cord. And then the remainder is between the 13 to the 17, which is again, even more important why we start to kind of change the curves and our way of thinking more in a transition zone to really optimize a fit in a shape like this.
And so we're really shifting our thinking of how to fit the lens, kind of looking from the inside to the outside, more at the internal landing zone and then towards the external, so that the toe there. And so now we'll get into the bi-elevation design here specifically and how it helps us better align that haptic fully to the eye. And so here's the bi-elevation design here. And the bi-elevation design of the Zenlens allows us to more customize the vaulting chamber, which allows us to bring that scleral lens landing zone kind of in towards the eye a bit sooner. And so we're not just adjusting at the very, very edge, at the very tiptoe, but we're adjusting at the internal aspect of the peripheral zone. So ultimately, this can lead to solving some sort of centralization issues and some fogging issues because of the better alignment of the lens to the eye.
I have to throw in there, because it makes me think if you were trapped on stuck on a desert island, and that's kind of what would you take with you? And I asked Carrie, who's on this call from BNL, if you had one figure that's super important to sum up exactly what the curves look like and what's your favorite, this is it. So this is a great figure that really highlights exactly what that lens design looks like.
And so how does the Zenlens Bi-Elevation design do this? Well, there's actually two different sags here. And so the vaulting chamber can have a more aligned fit, having the lens land just beyond the limbus, kind of at the up and down, maybe at the deeper sag, and then also at the side to side, which is maybe more of the shallow sag. And so this aligning a bit of more of an appropriate distance in the major meridians just beyond the limbus at the two different major meridians of the eyes maybe enhances the lens contact along the sclera there. And so then after we kind of get that alignment a little bit better within the vaulting chamber, then we after use the torque of the quadrant specific curve just to better align, kind of just fine tune it in the end. So the changing that we're making within the internal peripheral haptic zone, we are, it continues to extend out, and then we just add that little bit of a tweak at the end for the torque or the quadrant specific.
You know, when understanding this design, it was actually kind of interesting early on when our office started using this design, before we were, in the middle of clinic, we're not going to, when we didn't take the time yet to watch the fitting guide or the videos, and we knew about this technology and just wanted a lens. There's a few patients that I was struggling with decentration. And so I'd call Carrie and her team, can you just convert me to a bi-elevation design? And I'm talking a patient that had, a very highly toric sclera, maybe a difference between, vertical and horizontal by, maybe a 3 flat and a 7 to 9 steep or something like that, or a quadrant specific, which huge differences. When I ordered bi-elevation, I was like, no, it's straight converted. Yeah, it was straight converted from that crazy haptic lens on this crazy irregular sclera. And the lens that I got, the parameters initially did not make sense to me, because what you see is that the bi-elevation puts two different sagittal heights in that transition zone. And when that shape translates toward the edge of the lens, by the time it gets to that haptic, it's already toric. It curves right in and hugs those spots that are different in elevation. And so what my fitting parameters would be like, the bi-elevation difference of 300 or 400 microns, but a totally spherical haptic on a patient that I'd formerly fit, a 7 steep and a 3 flat. So it's kind of it's an interesting concept, and it really helps to understand that shape starts changing in the mid periphery, and it does extend out, and that helps to accommodate a highly irregular sclera as well. And so we've got some cases to kind of highlight. So again, this haptic alignment, again, in the limbal areas imaged in these videos, looks more like a potato chip than a regular old scleral, and it's, really cool looking lenses. Now, when it comes to lens fitting, we want to get to, for our last 10 minutes, we have some cases that we would love to go through with you. So that's where we're going to take you. We're going to take you on a journey in the clinic. And starting off, I'd like to just highlight and show this figure. Take a picture of this. This is awesome. This is a schematic that shows kind of a pathway. So when it comes to, there's an art, which is part of this, there's a science, and they all go together. Now, this is a wonderful sort of flow chart for deciding, okay, so do we have symmetrical scleral shape? No. Okay, then what do we do next? So this, again, we're not going to go through it step by step, but take a photo. This is a wonderful way to kind of differentiate in the clinic. Do we want a spherical haptic? Do we want to start with a bi-elevation? Do we need freeform? And this just gives a little bit of a great overview of how in the clinic. And to be honest, I haven't been following this step by step. When I read it over, this is exactly my process in the clinic for how we choose our haptics and the lens design. So let's start off with my favorite, maybe, the battle. So I'm very competitive, used to play sports. So we decided we could do a showdown, and we wanted to take a look, and we call this case report Battle of the Bi-Elevation. This is a patient of ours that we've featured before. This is Tori. She doesn't mind if we tell you her name. 30-year-old female, high prescription, lots of power, lots of sil, pretty healthy otherwise aside from dry eye. So she's always wanted to be fitted in sclerals. She's been a model in our videos for the clinic and for training before, but never had sclerals until this week. So we decided to do a head-to-head and utilize our technology in the software just to kind of literally apples to apples. This is not a patient that's had contacts before. And we decided to pull her ESP data and number one, look at how great of a candidate would she be for bi-elevation, which is going to come up here. Oh, and by the way, this is a nice map. I want to just highlight because we know junk in is junk out. And so I'm just going to pause to just harp on that a little bit. This is an example of nice real estate. We have, good full open eye. So this makes it very easy for us to design. There's a few little spots, of red where there's a little bit of dryness where she's got a pinguecula. But other than that, this is really, really good. Now, when it comes to where we're at in this video, over on this left-hand side, the first step in the clinic that we did was pull her cord length at about 12 millimeters. So that's where I'm going to continue on in this video. So what the software does at this point is it pulls this difference, this value here, the difference of 0.15, which is about 150 microns. That gives us the information about whether or not she would be a good candidate for bi-elevation. Now, generally, the fitting kind of recommendation is if we have a difference on our primary meridians at 12 millimeters, which is about around where the lens would maybe start to land. I think actually it's about 13 for 16 millimeter and 13.8 for a 17 millimeter lens. If we're at 100 microns, so 0.1 or greater, then there's enough of a difference that the patient's a good candidate for bi-elevation. So we take a look at that. Now, the next step is pulling the cord at 16 millimeters, where we would compare. So just type it in, hit enter, and you notice that the data changes. Now, this highlights that at 20 microns or 0.2 millimeters, 200 microns, majority of this patient's toricity is actually within the cornea. Next step for this patient, here comes the head-to-head, my favorite part. So we straight up empirically design lenses by utilizing the first lens fit feature that Ted mentioned. And no disrespect to the quad or the toric haptic, we use it all the time as well. But in this case, we knew she's a decent candidate for bi-elevation, so now let's prove it. So first lens fit calculated straight from the software, just literally from her eye data, a starting quad lens that we ordered from the data. So this is a single seg lens, 4750 for the height. You can see that her sclera is a little bit asymmetrical. And so we ordered that lens. Put diagnostic lenses on, by the way, prior to get the power, of course. And then we pulled our Bi-Elevation data, again, right from the software, empirically designed, so like 6 minutes. Now, these lenses came in very quickly, thanks to Carrie, and just so we could kind of have a look. And just to highlight here, this is really cool. I mentioned before in my kind of puzzle over how the parameters would change from a highly toric sclera to basically a spherical haptic with the Bi-Elevation. And this is an example. We have about 100 microns difference in the seg1 versus seg2. So that moves the curve in on that lens, pulls in the toricity inside the transition zone. And by the time that lens reaches the haptic, which would normally be more of a toric style, flat two. So that's a spherical haptic at the edge. Now, here are the results, quick and dirty. We don't mess around. Here's what we got. So on your left, you see the head-to-head with our quad haptic first lens. This was, a first lens fit dispense. Everything was fine on the first lens. And what I ordered was just a little bit different than, you can see the parameters of each lens. The quad versus the Bi-Elevation. Bi-Elevation centered better on the dispense and after the lens was worn for, some period of time. And subjectively, even with this low amount of toricity, the patient or our staff reported that she actually felt a little bit more comfortable. Now, the next step we're going to get into is our one fit wonder. So this is the utopia, the hole-in-one. So, of course, our ultimate goal is always to be able to, get to the final answer fast, hit that finish line without much effort, although that's never realistic. We put our heart and soul into these patients in these cases. And, but again, often more than not with digitally driven data, it is possible to have these fits that are, on difficult eyes, really simple and really fast. So here's a 38-year-old male, keratoconus, post-cross-linking. You can see on the map, and this is an example of a little bit of data missing on the top right. He had really tight lids, and so this is the best we could get. Few dry spots, not as nice as Tori's image, but still very usable. But it's very clear that this is more of a highly toric sclera if we just look at the scleral data. Now, when we come to the lens design, so here's where we started. This is kind of the same screen as we started on the video with Tori. So two different chords. 13.8 is imaged here, and 16.0 is imaged here. Here are the heights of the eye, or the difference, the toricity at those different chords. Now, this is an example highlighting that majority, at least half, around half of the toricity of this eye actually lands at the 13.8 millimeter area. Whereas different than Tori, the prior patient, this patient has, again, that toricity extending into the sclera. So 240 at the 13.8 and 470 out by the periphery. So what this tells us in the fitting guide is, as opposed to Tori, where we really were able to get most of that toricity right in that central transition zone, we do expect that with this patient, it's possible that the most optimal fit could actually come from a split where we put toricity in the transition zone and also expect a bit of a toric haptic in the end. So let's see what actually happened in clinic, because clinic is not always exactly like the textbook. So what we actually did in clinic was take this data, so we calculated it, but we didn't order empirically the way we did for Tori. We actually had the diagnostic fitting sets, and they come with a standard of about 300 micron differential. So for example, at this 13.8 millimeter or cord length, knowing that the eye has a toricity differential of about 240 microns, that is fairly well aligned with what's in a fitting set starting at a 300 micron differential. So we pulled a lens from the fitting set, which is a bit of an overshoot on the toricity at that transition zone, but we went with it. And this patient ended up being very successful with a little bit higher toricity than the overall being about 500. You can see the lens parameters below, where the haptic, the Bi-Elevation is about 4750 in one meridian and 5200 in the other. So that's roughly about, 400, a little more than that of microns of toricity within that haptic in that transition zone. Now, what usually happens is when we overshoot the toricity in that meridian, sometimes we see an increase in sagittal height of the lens. In this case, the patient did really, really well. And our final lens had a haptic at the landing, because we built it off of a fitting lens of a 4 horizontal steep, 2 vertical steep, which is really only a difference of about 60 microns. So basically, this patient ended up being fairly forgiving in the sclera, very happy with the lens, with a bit of a lean toward the bi-elevation in the mid-periphery of the lens rather than splitting it altogether. Now, this is what the clearance looked like. Really, really nice, beautiful. Landing is beautiful. Now, one thing I'll highlight, on first glance, this OCT of the edges, it's pretty close to primary gaze, but you can see the horizontal in 1 and in 2, beautiful, nice extension over the limbus. 3 and 4 in the vertical are just a little tighter. So we're still clearing the limbus, but not by too much. And so if we had split the toricity in that lens, the way that the software and the shape predicted, more so than loading it in the front and did a split, the result would have been more of an equal, flattened, sort of broader clearance of the vertical limbus. And it may have optimized it a little bit, may have not, but overall this patient was super, super happy. And one more case, and then we'll have some time for questions.
Yeah, one more case for where bi-elevation kind of solved all my problems here. And so we have a 36-year-old male, keratoconus, status post cross-linking. He has some ocular surface disease, ocular rosacea, MGD. And so when I delivered the first lens, this lens has no bi-elevation, so just one sag. You know, he came back 4 hours after wearing it. And when we saw him back, you know, I even saw from across the room, I was like, is that a hypopion? Like, what is going on? But no, it's just the fogging inside of that vaulting chamber.
So what you're talking about is that all that white junk in the bottom that's debris just accumulated there that looked like almost like danger, like white blood cells, but it's just a bunch of mucus.
Yeah, exactly.
Okay.
Yeah, it was only behind the lens. Don't worry, not in the anterior.
Not on the
chamber.
actual eye. Yeah.
And so this is related to maybe misalignment of the lens edge here. So you can see that the top there, it's kind of leaning on the heel, allowing some of the fluid to kind of seep in there, getting that debris under the lens. And then actually when you take the lens off, you can see that bottom part is kind of impinging there. And so this can kind of provide some discomfort, obviously the fogging that we saw for the patient. And so to resolve this, when we look at the actual Eaglet data, the scleral profilometry, at the 12mm cord, we can see there's an elevation difference of around 200 microns there. And then when we get out to the periphery, or almost to the periphery, it's still about that 200 there. So you can see it's all within that limbus. And so you can, just a quick mention here, why we have the 15 is maybe this isn't the best data. And so maybe if I kind of looked at this a little bit closer, we could train our technicians on how to increase that top data up there.
Back to the exactly. So the idea with any of our imaging is we always like to highlight quality of data. And even though this is a great case, which is why we included it, but we also specifically wanted to make sure that we reminded ourselves to mention the importance of high quality data and how much easier our life becomes. So for this patient, we don't see these. Our techs honestly do a lot of the heavy lifting. They're so wonderful. But what I probably would have done in this case, if we wanted to get a bit more real estate, then we probably just tip the head in different positions to align the eye more equally, and then just get a little more help with that lid lift.
And so to solve the problem, you can see we put the 200 microns of elevation difference within the sagittal height there. And then the periphery still stayed spherical. And so here's a picture perfect lens, and putting in that bi-elevation kind of solved my problems. The patient was happy, no more fogging. I was happy, the lens fit looks good. So maybe next time if I put the bi-elevation in on the first lens, I might have a one fit wonder like you.
Awesome. So guys, we really, really love the opportunity to come and spend time with you. Alia and I both want to thank the wonderful people that we have the pleasure of working with at, Eaglet, also at Bausch & Lomb, and also, a variety of different of our, it's a big community. And so it takes the kind of everybody to work together. And that's what we love so much about working with both of these companies, as it's, all about sort of rising the tide for everybody together as a team. And we really appreciate the opportunity to spend with you. So thank you so very much. And we do have a little bit of time for questions. We will stick around online, and I'll just pass this over. I could probably leave it on this screen so that everybody out there has a chance to go ahead and look up the contact information. There's some wonderful resources for those ESP users out there. Actually, I've noticed I popped onto the website. I love the Eagle and the newest digital sort of stuff, but a lot of the resources have been updated recently with a lot of work by the companies behind the technology. So
you do have one question from Dr. Lee, and it was the first case that you went over. He was asking, could you specify what meridian each sag value was for.
Yeah, for sure. I'm going to go back to that slide, and then I'll have you help, or, Dr. Lee, if you're on, if you feel like popping on your mic, if it's, or I guess maybe messaging if the audio is not possible, just to make sure that I can understand the question. Okay, so which meridian is each seg for in the video?
Yeah. So basically I just wanted to know when you had the bi-elevation differences in sag, I wanted to know what meridian you're specing, like for example, for this patient, their min sag lines around, horizontally. So with the lens.
Yeah. So I know what you mean. So basically, I'll have Elena speak to, or Ted to speak to the labeling, but we went over this, and basically what it is the difference is in the two primary meridians. So in this case, it's very, with the roll regular. And so the primary meridian in this case, she's actually shallow, like shorter this way and wider, broader this way. So in the horizontal. Does that answer the question? So like, so basically I see what you're saying. So the haptic in the seg 2, so the vertical we'll say would be the deeper haptic in this case. And the way that you can understand this is that most shapes honestly are going to have on average more of a width the rule corneal shape. That means that we're like a little higher in the horizontal, and not everybody. That's where like the irregular eye is totally different. That's why imaging is so important. So we get the lay of the land before we speak and before we make decisions. But on average, most tend to be. So in this case, normal patient, just dry eye, her shape of her eye is steeper and shorter in the vertical. And so for the transition zone of the scleral lens to accommodate that, the height gets higher so that it'll kind of curve back and land where the eye is further away from the front.
And
does that make sense?
Yeah, and that's been my experience too. I just wanted to make sure that that was the case
Yes.
with the okay.
Absolutely. Yeah, absolutely the case. And it really just varies. So everybody's a little different, but on average, that's exactly how you can imagine. And then the cool thing so thank you for this question. It just allows us to go further in this patient because of that shape already extending back and reaching to touch. We're really just dealing with what is the fitting relationship between a piece of plastic and a tissue. The plastic is going to hit the tissue that it touches first. And in the vertical, it's further away because it's a steeper curve. So that lens has to extend back further, having a higher sag there to actually make contact at the same time as the horizontal.
But another thing is, I will be honest, most of my patients have these oblique axes anyways, like the last part.
Yeah. And that'll be where the lens will rotate to its home. So the lens is going to go to the path of least resistance. And of course, there's going to be patients. And that's where, in all fairness, when it comes to optimizing, these are toric designs. There are applications that in, highly irregular eyes, post-surgical, maybe this toric haptic isn't the perfect fit. It still is usually going to land at the place of least resistance. It's kind of like a lock and key. So it would be not uncommon for your oblique patients. You order with toricity, just like, the haptic would have landed with a little bit of rotation. So would that inside haptic as well.
Yeah. And so when I'm adjusting the sag after the BE, I'm kind of looking at their own meridian, like you said, like based on eye. Would you that, or?
Can you repeat that? It just cut out for one part of what you said.
So when I'm adjusting the sagittal depth after putting a patient on a BE and they're oblique, I am measuring their like the clearances in their respective meridians versus just superior, inferior, nasal temporal.
Yeah.
You recommend that?
Yeah, so you'd look at where the lens is, and my recommendation would be it's the same as how you would change the haptic on a lens that rotates, is you would note the rotation of the lens, note what you're seeing, and involve your consultation team, because these patients, it's not going to be perfect, honestly. Like, it's not like Tori, who's got that toric shape, or that patient I showed you with really a clear toricity. Some are going to be more irregular, and irregular eyes, again, could be a perfect example. It sounds like an oblique shape. You should be able to fit very easily with a bi-elevation. Some patients, if it's too irregular, that's where we would then reach for maybe a freeform or impression driven, where it can be a little more customized with the same concept of optimizing that shape in the transition zone, where we can minimize the things that cause decentration and cause chronic kind of like misalignment when it comes to that fitting relationship.
Awesome. Thank you.
Thank you so much for asking questions. It's a lot more fun. It's like real people are out there. So good.
Okay, it looks like that might be all the questions for now. If anybody has more questions later on, feel free to contact us or contact Dr. Morrison and Dr. Cappellani, and I'm sure they'd be happy to help you out. But thank you everyone very much for spending the time with us this evening. Thank you, Dr. Morrison, Dr. Cappellani, for excellent cases and presentation. Really appreciate it. And it's been just a great educational night. So again, thank you, everybody. Have a wonderful holiday wherever you are in the world. And we look forward to seeing you sometime soon.